morning. This is the last lecture, Retention and Relapse, and I'll follow up with some review questions. As the famous baseball legend said, it's not over till it's over, which means that orthodontics takes a long time. If we're treating somebody in the permanent dentition, let's say we start 10 or 11 years old, a treatment might take 2 to 3 years in a single phase of treatment. Remember, we also have early treatment too, something like class 3 retrognathic maxilla, where we use a face mask. So in a phase 1 treatment, we see the patients for on the order of a year. We take off the appliances, go into a holding phase, observation phase, and then most of the time, it turns into a phase 2 or comprehensive as well. So phase 1 orthodontics doesn't eliminate phase 2 or comprehensive orthodontics. Maybe 20% of the time we get lucky and we don't have to present a phase 2. But I always tell patients that phase 1 is followed by phase 2, and then they're not discouraged. I've had patients come in from some other orthodontists in the area, not so much today, but years ago, and said they complained because their orthodontist said it was a preventive type thing, like a vaccine or a fluoride treatment or something. You have the phase 1 done and no phase 2 was necessary. And then they were told they had a phase 2 need and they were really mad. So phase 1 is usually followed by phase 2. That length of time might be then on the order of 6 years. We want balance between teeth, bone, and muscle. One author defined retention as the holding of teeth in ideal aesthetic and functional positions. It was a rather landmark study a long time ago, 1981, and it was stability and relapse of mandibular incisor alignment with first premolar extraction cases treated by traditional edgewise orthodontics. It was a longitudinal study, so patients were seen and followed for a number of years. And it looked at braces being removed in 10 years after that. In those patients, 10 years after orthodontic treatment, 30% had perfect alignment, 20% had marked crowding, and the balance had some crowding. That is really sobering information. And if I saw this article, I don't know if I would have gone into the orthodontic profession. It's like saying that you undergo a procedure and you're only successful 30% of the time. Imagine that, 30% of your crown and bridge is successful, 30% of your implants is successful. Well, there were some strategies to change the way retention was done that largely improved the results of that 1981 study. And we'll talk about that later. Causes of relapse are many. Unfavorable growth patterns. We can incorrectly place teeth over the basal bone, especially lower incisors move too far anteriorly. We can have the incorrect arch form relative to muscle function, such overexpansion, which is resisted by cheeks and lips, overcontraction resisted by tongue, and as a slide showed, I think about 2 lectures into the series about soft tissue wins, it's fitting that soft tissue wins is a phrase we'll see again that we're seeing now in this last lecture. Other causes of relapse, tendency for overbites to return. If you don't have parallel roots, especially near extraction spaces, that is tip teeth, that will promote relapse. Incorrect relationship of inclined planes. We want correct functional stresses and habits. Any place there's a habit that will contribute to relapse. Causes of relapse are seated in the soft tissue fibers surrounding the roots in bone. The periodontal fibers surrounding most of the root rearrange or readapt in a relatively short period of time, 8 to 10 weeks. The alveolar crest fibers take a lot longer to rearrange, on the order of a year or more. So we want to hold teeth with a retention device for a long period of time. That was the problem in the 1981 findings. That being that orthodontists in that era were telling patients, okay, wear your retainers for a month, throw them away, wear them for a year, throw them away. That's not the case today. We have to do long-term retention, even greater than a year. Not full-time, we'll get into that later, but a gradually diminishing period of retainer wear. The limits of stability for the mandibular arch. This shows that we can move lower incisors forward a bit, maybe 2 millimeters. If we have crowding, that will help in the crowding. We couple that with interproximal reduction, or IPR. We can add maybe another couple millimeters to that. But the crowding, the limits of crowding correction are on the order of 3.5 millimeters or so, 3.5, 4 millimeters. The literature shows that expansion in the lower canine area is very resistant to expansion. We can get a little more expansion as we travel posteriorly, but if we expand the lower cuspids, they really have a tendency to want to move back. And of course, the limits of the lower arch determine the fit or the occlusion of the opposing upper arch. Here are the fibers that I mentioned. Most of the fibers, including horizontal, oblique, and apical fibers, reorganize rather quickly, 8 to 10 weeks. The crestal or supracrestal fibers take a lot longer. Other causes of relapse: tooth size discrepancy, happens all the time. Eruption of third molars. Some or many advocate early extractions, but there's no proven cause and effect. This was covered earlier on. Local hereditary factors. There's some genetic factors that cause relapse tendencies, specifically maxillary laterals. Remember, they're flared in Class 2 Division 2 cases, and they want to go back to their original positions. Other causes of relapse: variations of chewing, speaking, lip, tongue, cheek function. Now the types of retention. You can have no retention, limited retention, and semi-permanent or permanent retention. No retention: if we correct anterior and posterior crossbites, they tend to be very stable. Teeth separated for eruption of a blocked out tooth, like this lower blocked out